Hypertension in which cause is identifiable is called secondary hypertension. About 5 to 10% patient of hypertension has secondary cause. Hypertension number 2, increase liability or acute rise in blood pressure. Hypertension that develops in non-black patient less than 30 years of age. Patient with severe hypertension, BP remain more than 180 by 110 most of the time, along with early organ damage. Hypertension associated with electrolyte disorder like hypokalemia or metabolic alkalosis. Non-dipping or reverse dipping present while monitoring 24-hour blood pressure. In routine during sleeping time, blood pressure fall as compared to the daytime. That is called dipping. If patient there is no dipping or sometime blood pressure increased during sleep, that is called reverse dipping. So these are the clues for secondary hypertension. So whenever any of the clinical or these feature present in patient, then think about secondary cause of hypertension. What are the causes of secondary hypertension? Very simple. Remember, only there are four categories. Number one is the renal. In renal, there may be parenchyma or renal vasculatures. Number two is the endocrinopathies. In endocrinopathies, most common cause is the aldosteronism. Cushing, hyperthyroid, hypothyroid, hyperparathyroid, pheochromocytoma. These are the common acromegaly. These are the common endocrinopathies that can cause hypertension. Vascular system, coarctation of aorta. And number four, miscellaneous causes, which includes obstructive sleep apnea, drug-induced hypertension, pregnancy, scleroderma. Most of the time, patient present with acute elevation of blood pressure. While patient is diagnosed case of hypertension, patient was stable on medication. But sometimes patient blood pressure remain high. What are the causes of elevated blood pressure? Always think about secondary causes. The most common cause of secondary causes in already hypertensive patient is the drug-induced hypertension. So what are the causes of drug-induced hypertension? We will discuss in the next slide. Now, what is the differential diagnosis of elevated blood pressure, a cause of increased blood pressure? Number one is the chronic kidney disease. Number two is autosomal dominant polycystic kidney disease. Number three, renal artery stenosis. Number four, fibromuscular dysplasia. These four are the causes of renovascular systems. Number five, these are no endocrinopathies: primary hyperaldosterone, Cushing, hyperthyroid, hypothyroid, hyperparathyroid, pheochromocytoma, acromegaly, congenital adrenal hyperplasia, coarctation of the aorta, obstructive sleep apnea, drug-induced hypertension, pregnancy, and scleroderma. Basically, all the etiology is the differential diagnosis of secondary causes of hypertension. So the very important, always think about drugs, because most of the patients are on medications, multiple medications. These medications may precipitate the hypertension, may impair the action of antihypertensive medications. So number one is the non-steroidal anti-inflammatory drugs, acetaminophen and aspirin. Sodium-containing antacids, drug used to treat attention deficits. Antidepressants, atypical antipsychotics, decongestant, phenylephrine, pseudoephedrine. Herbal supplements like ephedra, euhimbine, estigone, systemic corticosteroids, mineralocorticosteroids, oral contraceptives, immunosuppressants, chronic recombinant human erythropoietin, recreational drugs, nicotines, chemotherapeutic agents. No, very important, how to elaborate patient presenting with hypertension, or if you are suspecting secondary cause of hypertension. First of all, history and examinations. Ask about, first of our differential is renal vasculature. So elaborate the renal system very carefully. Renal insufficiency, atherosclerotic cardiovascular disease, and edema. If all these present, then further evaluation of chronic kidney disease or renal parenchymal disease is very important. Ask about the history of recurrent UTI, kidney stones, flank pain, hematuria, progressive renal failure. These may point toward autosomal polycystic kidney disease. That is another cause of the renal parenchymal disease. Then ask about the weight gain, change of weight, fatigue, weakness, hirsutism, menstrual irregularities if patient is female, moon face, dorsal hump, purple stria, truncal obesity. These may suggestive of Cushing disease. Then ask about the fatigue, weight loss, hair loss, diastolic hypertension, muscle weakness, heat or cold intolerance. This may be the underlying cause of hypothyroid. If patient has heat intolerance, weight loss, palpitation, systolic hypertension, exophthalmos, tremor, tachycardia, there may be the hyperthyroid. If patient does give history of the osteoporosis, kidney stone, depression, lethargy, muscle weakness, then think about the hyperparathyroidism. If there is headache, fatigue, visual problems, enlargement of the hands, feet, and tongue, then there may be the acromegaly. If patient does give history of snoring, obesity, and daytime sleepiness, could be indicative of obstructive sleep apnea. Heartburn, Raynaud phenomena, nail biting on the exam may be suggestive of scleroderma. How will you investigate the patient presenting with hypertension? There are four type of investigation. Number one is the renal parenchymal disease. Do the urine complete renal function test and angiography or MRA Doppler of the renal vasculature. Number two, and do the endocrinopathies. First of all, do the serum electrolyte, serum calcium. If you are strong suspicion of endocrinopathies, then do the aldosterone to renal ratio. If greater than 30, then it is suggestive of the primary hyperaldosteronism. Do the thyroid function test and parathyroid level and free metanephrine level for catecholamine or for pheochromocytoma. Then do the chest X-ray. There will be the figure of 3 on echocardiography for coarctation of aorta. Number 4, do the CBC for polycythemia, rubra vera, lipid profile, and hyperlipidemia may associated with hypertension, and do the sleep study, as obstructive sleep apnea is an important cause of hypertension. So these are the investigations which should be carried out in patient if you are suspecting secondary cause of hypertension. Now next is the thank you very much.